Hi, welcome to Unit 20, Part 2, and these are the different sections. We're looking at disadvantage, inequality, class and status, health and well-being, and then meeting the needs of young people. Disadvantage. The traditional idea of disadvantage was linked almost solely with economic factors such as income and levels of unemployment. So when an individual fell below the poverty line based on national average income, they were considered to be disadvantaged. And that'll help you with question 16. There is a problem with this, with understanding disadvantage just by income. It's not accurate and it is not useful because it does not differentiate between people on low incomes, some who are doing well and some who are not doing well. So it doesn't differentiate between those two groups. There are many things that can contribute to disadvantage, not just income. And suggesting that disadvantage is just about income suggests also that one act of giving more income will remove the disadvantage. And this is not the case for many people who suffer disadvantage. So it's a bit like this. We've got two communities here, and they both have low incomes and high unemployment. So that means that they're both disadvantaged. But it's not that simple. This community here is doing well. This community here is not doing well. So this community here, there's higher levels of mistrust, there's isolation, people don't know each other, kids are encouraged to stay indoors, there could be high levels of drug use or alcohol abuse. But this community here, the people know each other, the people get on, they have meetings together, they have social clubs, social institutions, sporting clubs, that sort of thing. So can you see how they're both disadvantaged in terms of income, and yet one community is not doing well, one community is doing well. So I hope that explains it. We have community disadvantage, and this is where we have factors that make it difficult for people living in certain areas to achieve positive life outcomes, and that's factors to do with employment, education levels, drug and alcohol use, all of those sort of things. It's also to do with weak social networks, poor role models, and a relative lack of opportunity. If we look at social capital refers to strong and healthy social customs and networks, and then of course the numerous benefits that can bring to a community. So it enables coordination and cooperation for the mutual benefit of those people in the community. And there's an example here. So it's two communities in the same city where both meet the traditional label of being disadvantaged because of low income. So you've got these two communities, they've both got low income. But the first community, number one, is marked by a general feeling of isolation and mistrust. The neighbours do not know each other. Children are encouraged to stay indoors or in the yard rather than to play with friends on the street or in parks. Most community members rarely gather together to discuss matters of a collective importance. And so we would say that that community is low in social capital. And then we have a second community, same low income, but they are high in social capital because the neighbours enjoy this kind of give and take relationships where they look out for each other, where they're visiting each other. They have things like neighbourhood watch. They're helping with each other's children. They've got football clubs and other clubs. The school and the clubs are popular meeting places. There are town meetings, and community members generally agree or understand how they should behave towards one another. This is a positive, friendly community, and this community is high in social capital. And so a community like this is much more easily able to draw together in difficult times. And I mean, we think back to the bushfires before Christmas, and a community like this could draw together and help each other during these very difficult times. So looking at those two communities, even though both communities have the same level of disadvantage, they have very different levels of social capital. So I hope you understand what that social capital actually means, and that will help you with question 18. Social inclusion and social exclusion. Social inclusion
is the opportunity to participate in a society through employment and have access to services, connect with family, friends in the local community, deal with personal crises, so ill health, bereavement, that sort of thing. It's also about being heard. And so this is the first part of question 19. Social exclusion, and the factors there are unemployment, poor skills, poor housing, high crime involvement, bad health, family breakdown. Social inclusion and exclusion and social capital both agree that positive social connections strongly contribute to the overall well-being of a community. So do you see that? Social inclusion and exclusion and social capital, they both agree that these positive social connections strongly contribute to the overall well-being of the community, and that the lack of these relationships contributes to disadvantage. This includes Aboriginal and Torres Strait Islander people, people from areas of socio-economic disadvantage, people in rural and remote locations, and people with disability. These disadvantages can include higher rates of illness and shorter life expectancy. Indigenous Australians experience widespread socio-economic disadvantage and health inequality compared with non-Indigenous Australians. Indigenous Australians are 2.9 times more likely to have a long-term ear or hearing problem. They're 2.7 times as likely to smoke, 2.7 times as likely to experience high or very high levels of psychological distress, 2.1 times more likely to die before their 5th birthday, 1.9 times as likely to be born with low birth weight, 1.7 times as likely to have disability or restrictive long-term health conditions. So you can see that Indigenous Australians do experience this disadvantage with their health. The differences between Indigenous and non-Indigenous Australians, what we call the health gap, is caused by social determinants, health risk factors, like smoking, and access to appropriate health services. If we look at socio-economic groups, compared with people in the highest socio-economic group, people in the lowest group are 2.7 times more likely to smoke, 2.6 times as likely to have diabetes, 2.4 times as likely to state cost as a barrier to seeing a dental professional, 2.3 times as likely to state cost as a barrier to filling a prescription, and 2.1 times as likely to die of potentially avoidable causes. When we're talking about these rural and remote factors, about 3 in 10 or 29% or 7 million Australians live in rural or remote areas, and they have difficulty in accessing services. They experience poorer health outcomes than in major cities. They're more likely to engage in behaviours associated with poorer health. For example, about 1 in 5 smoke compared to about 1 in 8 in major cities. Then we look at employment and income, and this will help you with question 25. Access to well-paid full-time employment is important. It's almost a prerequisite to enjoy the rewards of the Australian economic system. And, what comes along with that, of course, is superannuation, healthcare, sickness and accident benefits, etc. People who do not fit this model, who do not have well-paid full-time employment, are unemployed part-time workers and have low-paid employment. We have what's called a dual labour market. We have secure employees on regular pay, and then we have these others, peripheral workers, whose role is much more marginal and who are liable to be displaced during economic cycles. So during an economic cycle or a downturn, they would lose their job. And then we have the precarious, or the role of the marginal workers who move between casual part-time work and joblessness. Unstable economic conditions for workers also leads to social instability. Good employment leads to equity, security, dignity and freedom. So you can see that, having that good employment is just so important for social conditions as well. Then let's look at the long-term unemployed, and this will help you with question 26. Who are the long-term unemployed? In Australia, there are about 175,000 long-term unemployed, so they haven't worked for 12 months or more. And of these, 94,000 have been out of work for 2 years or more. Some groups are overrepresented in this group of long-term unemployed, and they include the less well-educated, with 49% of these not reaching Year 12, Indigenous people, mature age people, and people with disabilities. Some locations have got a much higher rate of long-term unemployment than others, and these communities often have social, health, and infrastructure disadvantages. So what are the impact of long-term unemployment? It's associated with poor physical and mental health, social isolation, and poverty. Workers who remain outside the workforce for some time find it much, much harder to re-enter. And then we have the effect of long-term unemployment on families, and that includes things like increased family stress and reduced outcomes. Financial stress affects the emotional well-being of mothers. Children have worse academic performance. It's detrimental to the emotional well-being of children. There's higher rates of crime and violence. There's increased cognitive distress and depressive symptoms in adolescent children, and worse labour market outcomes. And that will help you with question 27. Then let's look at age discrimination. Australia's work participation for older workers is less than many OECD countries, and discrimination by employers is a key factor. Issues for older Australians are they cannot access employment opportunities because of their age. They are not told why they have not been employed. Older Australians are often treated poorly while seeking employment. Older Australians find the process demoralising and damaging to self-esteem. They need to apply for a large number of jobs before they're given an interview or accepted for employment. They have to apply for jobs that are below their skill level and experience because of their age. And there are some industries or areas such as IT that have poor records for employing older Australians. The Age Discrimination Act covers these situations where an older person is refused employment, dismissed, denied a promotion, transfer, etc., given less favourable treatment, denied equal access to training opportunities, selected for redundancy, and harassed. And that will help you with question 28. There is also educational disadvantage in Australia, and that has 3 dimensions. And so we're looking at opportunities, experiences, and outcomes. Opportunities, this is around the access that students have to resources and facilities, as well as to effective teachers. Experiences, this includes students' relationships and interactions with the teachers and fellow students and their sense of belonging in their school and their experience of classroom discipline. And outcomes, how the students turn out in terms of character as well as the skills and knowledge that they gain. So let's just have a look first at inequality of opportunity. And these will help you with question 29, these next few slides. Australia has a large gap in the shortage of teachers between disadvantaged and advantaged schools, between urban and rural schools. Low socioeconomic schools have far fewer materials. So there is this gap here. There is a shortage of teachers for disadvantaged schools. Then we have inequalities of experience. There's higher levels of noise and disorders in disadvantaged schools. It's a less supportive and engaging relationship with teachers in disadvantaged schools. And then, of course, we have inequality of outcome. And this is like the achievement gap between the advantaged and disadvantaged student. This is quite large, and it's equivalent roughly to 3 years of schooling. There are also large achievement gaps between Indigenous and non-Indigenous students. For example, 47% of Indigenous students meet the minimum proficiency science standards in TIMSS, compared to 77% of non-Indigenous students. So that's 47% compared to 77%. So quite a big inequality of outcome. In recent United Nations reports on education, in OECD countries, Australia was ranked 36 out of 41 countries in equality in preschool attendance, 25th out of 29 countries in inequality in primary school reading achievement, and 30th out of 38 countries in inequality in secondary school reading achievement. So, we do have this inequality in education. This report found a clear link between social segregation and education performance in Australia. There were large inequalities in children's educational progress linked to their family background. Inequalities already exist when children enter preschool, and they persist at primary and secondary level. Class and status. It's interesting because when you talk to Australians, they regard themselves as classless or fully equal. And while most Australians would like to think we're all equal, this is not the case, because there is huge differences in Australia between financial resources and assets, income, status, employment, home ownership, clothing, education, speech. So there's lots of changes. And while Australians don't like to accept that there are classes in Australia, there have been books, movies, TVs based around class. Kath and Kim, The Castle are typical examples. And there's also some class-type terminology that's still used, such as bogan, rednecks, society elite, that indicate class or status. This will help you with question 30. Class and status can refer to economic position. So there are clear economic differences between people depending on how much money they have, their employment status, and the kind of income they have. It can refer to productive relationships. So the main distinction falls between those who own the means of production and those who sell their labour, so employer and employee. But there are also other classes, such as those who own small shops and businesses, or those who are just marginal to the labour market, so maybe part-time workers. And then occupational status. Classifying people by occupational status is useful in looking at other issues, including educational disadvantage and health inequalities. So what about status? Status is a kind of form of social honour or esteem. A person's social rank is associated with their class, but the terms are not equivalent. Some social roles have high esteem, but low resources, etc. The recipients of welfare, people who get welfare, tend to be people of low income, who then tend to be stigmatised as less esteemed. In part, this happens because the client group of the social services tends to be people who already have lower self-esteem. So these are people who don't have very many resources. They're poor people, disabled people, mentally ill people, single parents, and so on. There's been a new study come along. It was published in 2017, and it shows a shift in the old working class versus middle class view of how we look at identities. It moves instead towards 6 classifications, and these are analysed based on age, culture, economic influence, etc. And it also explores social influences, like whether we go to the gym, whether we go to opera, all that sort of stuff, and the types of people that we spend time with. And here they are. The first one is the precariat. So this is 12%. This is characterised by high numbers of retired pensioners and students who tend to live week to week, often with little in their bank account. Those still working are likely to be labourers rather than managers. So that's one group. Then you have the ageing workers. 14% are obviously the oldest Australians, which make up the 14% of the Australian population. Similar to the precariat, this category includes many pensioners with little funds, but slightly more funds to keep them out of the bottom group. So you see how that works? They typically come from more advantaged backgrounds than the precariat group. Then you have the new workers, about 24%. These are younger workers than the ageing workers, predominantly labourers and white-collared workers. This group is financially better off, despite being of slightly lower class. They also have the lowest rate of unemployment. Then we have the established middle class, 24%. It's the highest rate of unemployment, but also includes higher numbers of self-funded retirees, as well as more people working in the community services sector. Then we have the emerging affluent, 15%. This is the youngest group, encompassing the most full-time workers as well as the most part-time workers of the 6 groups. They're highly educated and measure the highest in prestige, presumably having a majority of double income households. So that's the emerging affluent. And then we have the established affluent, it's about 11%, comprises the highest level of occupational prestige, so doctors, lawyers, etc., made up entirely of managers and professionals. They're also more likely to attend cultural and musical events such as theatre, live music, go to the gym, etc. So there we have those 6 types of social classes that they have identified in Australia in this most recent study. Precariat, ageing workers, new workers, mobile, established middle, emerging affluent, established affluent, and that will help you with question 31. 20.8 Optimal health and wellbeing outcomes for young people. The Australian Research Alliance for Children and Youth identified collectively across Australia a framework of optimal outcomes, the best possible outcomes to achieve for children and young people aged 0 to 24. They called this a NEST because it's a National Action Plan. This is what they said. They said, through the NEST, we turn evidence on what works for children and youth wellbeing into practical, preventable action to benefit all young Australians aged 0 to 24 years. And this is off their website. These outcomes, or shared vision for Australia's children and youth, is an Australia where all young people are loved and safe, have material basics, are healthy, are learning, are participating, and have a positive sense of identity and culture. And this will help you for question 32. And you can see the framework here. It's got the vision, it's got how it's measured, and it's got different outcomes across all the different fields. We're going to just have a little bit of a look at some of these. So, being loved and safe. This embraces positive family relationships and connections with others, and personal and community safety. Children and young people who are loved and safe are more likely to be confident, to have a strong self-identity, have high self-esteem, have greater capacity to form secure attachments, and have positive adult role models or mentors in their lives. Children and young people who are loved and safe tend to be more resilient, they can withstand challenges, and they can respond constructively to setbacks and unanticipated events. So that's the first one of these outcomes, loved and safe. The second one is material basics. Children and young people who have material basics have access to the things they need to live a normal life: adequate and stable housing, adequate clothing, healthy food, clean water, and the materials that they need to participate in education and training pathways. For young people, access to material basics supports them to make effective transitions to adulthood, greater capacity to achieve secure housing, to live independently, and to receive an income that enables them to provide for themselves, and so on. So that's material basics. And then we have healthy. Healthy children and young people have their needs met in areas of physical, developmental, psychosocial, and mental health. This means they have greater opportunity to achieve their optimal developmental trajectories, and so on. You can read it in the notes. And then we come to learning. Early engagement and participation in learning and education is important for the development of children and young people. Learning is a continuous process throughout life. Children and young people learn through a variety of formal and informal experiences within the classroom, and then more broadly in their home and the community. Effective learning and educational attainment is fundamental to future opportunities both financially and socially. Then we have participating. This includes involvement with peers in the community, being able to have a voice and a say on matters, and access to technology for social connections. In practice, it means children and young people are listened to, are supported in expressing their views, their views are taken into account, and they're involved in decision-making processes that affect them. Then the last one of these outcomes or these shared vision statements is a positive sense of identity and culture. Having a positive sense of identity and culture is central to the well-being of children and young people, and is particularly important for Aboriginal and Torres Strait Islander children, and also other culturally and linguistically diverse children and young people. This outcome includes having a sense of spiritual well-being. It underpins and is fundamental to the other child and youth outcome areas. And so these are the outcomes or the shared vision for Australia's children and young people, and you can see the outcomes there. 20.9, meeting the needs of young people. If you use a case management approach, this is an effective way to clarify the needs of young people, to help you identify socio-cultural impacts, to provide services to meet the needs of these young people, have an organised, systematic process, and to coordinate all the people and all the services who can contribute to meeting the needs of young people. So you would coordinate them in meetings generally. A case management process is dynamic and ongoing, and it is monitored and reviewed regularly so that it continues to identify and respond to the needs of the young person. In meeting the needs of young people, there are 8 steps. The first is gathering information, clarifying needs and strengths, identifying impacts and risks, making informed decisions, providing services and support, monitoring services, reviewing effectiveness, and then revising as required. So let's just unpack those a little bit. So the first is about gathering information. How do we gather information? We do this by collecting data and information from effective professional relationships where there's an open, transparent communication pattern, non-formal screening, which includes observation, conversation, and sometimes interviews, and lots of written documents such as school application forms, medical reports, school reports, incident reports, screening reports, records, all that sort of thing. And this step, gathering information, it should involve discussion and protocols around privacy and confidentiality, rights and respect, that sort of thing, and responsibilities, who's responsible for what. Next, we look at clarifying needs and strengths. And so this would be formal screening and assessment by professionals, reports and other written data, conversations with the young person and their support, such as their family, and seeking professional advice where we need it to clarify the needs and strengths of the young person. And then just identifying impacts and risks. So we consider all these different domains such as home and environment, education, employment activities, alcohol and other drugs, relationships and sexuality, conduct difficulties, anxiety, eating orders, psychosis, etc. All of those come from Headspace psychosocial assessment for young people. But we analyse the information available with a team of people so that we can identify impacts and risks. Then we make informed decisions on the available data and all the impacts identified. We try and work out who will be involved in the process, how will the young person be involved, what supports are required. Where are those supports going to come from? Are they going to come from in your own organisation, from another organisation, from consultants, from external professionals? You'll have a timeline for supports and a timeline for meetings, etc. And then the next part of this, of course, is to provide services. And the services provided to the young person should be based on careful assessment by appropriately qualified people. They should involve the young person in decisions, particularly about their own treatment. They should involve internal and external supports as required, should be based on individual action plans or case plans, and they should include a process where all of the people, agencies, providers view data, plan, meet together in order to provide the best possible coordinated response to meet the needs of the young person. Then we monitor the services. The individual action plan or case plan should include a process for accurately and regularly monitoring the supports, making sure the support is occurring as it's planned, the young person safe at all times, any changing needs, and there's often changing needs, any changing needs are addressed, and the support provided is effective in bringing about the required change. Then we review the support. So we should review or evaluate the support provided to see if it's achieving the desired outcomes, to see if it should be continued, or to see if it should be revised. And then often we will have to revise the support. If the reviewers identified that the support requires revision, then the case plan should be changed so that optimal support, the best possible support, is provided for the young person. The review might also identify that the support cease because the need has been met or for a range of other reasons. You'll see that assessment question 33 says, read section 20.9 and list the 8 steps. So we've just talked about those 8 steps. Then read the Rowan-Dawson scenario, and in the table below, show how each of the steps was addressed in meeting the needs of Rowan-Dawson. And the table looks like this, and you can see there's a table there about gathering information, clarifying needs and strengths, and so on. So let's have a look at Rowan-Dawson. So we're looking at this scenario of Rowan-Dawson. He's at Mitford School, he's age 14, he's in year level 8, and he's in boarding. And we've got a whole lot of documents, including Mitford application form, health evaluation form, a DCPFS report, and a previous school report. So here's some information about Rowan. Rowan's a 14-year-old student who is in out-of-home care with the WA Department for Child Protection and Family Support. Last year, Rowan was living with his grandmother, but she has recently moved into supported care facility and is no longer able to care for Rowan. An uncle and auntie care for Rowan's younger brother and have been approached by DCPFS to care for Rowan when he's on holidays from the Mitford School. Rowan came into the care of the department at age 12, and the DCPFS report indicates that Rowan had lived with his mother for most of the 12 years, although he had also been in foster care on 4 occasions, the longest time being 18 months. His mother has a mental illness and has been institutionalised several times. Rowan and his mother have lived at times with her de facto spouse, with other family members, or in a refuge, but for the last 3 months before Rowan came into care, they were living in a car. His auntie advised the school that his mother is currently homeless and transient, and there has been a history of domestic violence in the de facto relationship. Contact with his mother is very irregular. Rowan has been boarding at Mitford for 3 weeks, and supervisors are concerned for the following reason. Rowan's not engaging with other students or forming relationships. He avoids other students and spends a lot of time alone in his room. Rowan is not engaging with the residence program and rarely gets involved with activities, outings and excursions. There have been minor bullying incidents. 2 older students have become frustrated with Rowan's avoidance behaviour and have tried to force him to be involved in activities. Other students are also uncomfortable with Rowan's behaviour. Rowan frequently complains of stomach aches or cramps. Rowan is very fussy with his food and doesn't eat fruit or vegetables, or certainly doesn't like eating fruit or vegetables. So we look at the first process here. And I just want to remind you about this slide here. When we're looking at the process of gathering information. And so what we want to look at is, how did these Mitford boarding staff, how did they gather the information about Rowan? So gathering information. Andrew is a senior boarding supervisor at Mitford, and he completes a report on Rowan-Dawson for the head of boarding, Jackson Dinning. The report is based on documents in Rowan's file, including these documents: application form, health evaluation form, DCPS report, previous school report, incident reports, interview notes with Rowan, interview notes with other students. The report also contains the observations of Andrew and other boarding staff. So this first little table here, how did Mitford staff gather the information? If you fill it into that first table there. The second step is to clarify needs and strengths. So how did Mitford staff clarify needs and strengths. The head of boarding, Jackson Dinning, interviews Rowan and explains to Rowan why he needs to have some assessments and what are some of the possible outcomes from the assessments. Rowan agrees to the assessments. Jackson then arranges for Rowan to have a health check with a Mitford nurse and a formal assessment by a local qualified youth counsellor. He also has a restorative interview with the students who've been involved in pressuring him. Jackson asks Andrew to case manage Rowan. So this means that from this point on, Andrew will case manage Rowan. This process enables Andrew and Jackson to clarify Rowan's needs and strengths. Andrew supports Rowan by taking him to appointments, introducing Rowan and listening to Rowan's feedback after the visits. Andrew invites Rowan to explain about his interests and also about his Aboriginal heritage. He asks Rowan if he would like to meet people from the local Aboriginal Corporation or from the Clontarf Foundation Sports Academy at the school. Rowan's unsure about this, but he agrees to think about it. Rowan does express an interest in soccer and in joining the school soccer club. Rowan has heard about the Friday afternoon cooking club, and he tells Andrew he would also like to learn cooking and join that club. So, just going back to this table here, clarifying the needs and strengths. How did the Mitford staff clarify those needs and strengths? And we don't want you just to copy and paste that whole lot of text into there. We'd like you to look at that and work out what process did they use to clarify those needs and strengths. The next process is identifying impacts and risks. Jackson organised a meeting that includes Andrew, the DCPFS caseworker, the school nurse and the counsellor. Rowan is also present for the first part of the meeting. The agenda for this meeting includes the possible impacts of social, cultural factors in Rowan's life prior to Mitford, his rheumatic heart condition, his strengths, his interests, his needs, his concerns, and any possible risks to Rowan. And so that is the step, identify impacts and risks. The next part is about making informed decisions. This is the next step. Based on all the information gathered and the discussion during the meeting, Andrew, Jackson, the DCPFS caseworker, the school nurse and the counsellor and Rowan agree on this. These are the steps. The first is counselling meetings twice a week with the counsellor, a health plan to manage the rheumatic heart medication, joining the school soccer club, involvement in the Friday afternoon cooking club, an exercise plan, and regular contact call with his family. So that's the step, make informed decisions. The next step is providing services and support. Andrew supports Rowan, taking him to counselling meetings twice a week. Andrew and the nurse develop a plan to manage Rowan's medication. Andrew takes Rowan to the soccer club, introduces Rowan, and organises for Rowan to join the club. He's arranged for Rowan to have regular phone contact with his family, and he's asked DCPFS if he can get a mobile phone, so he's asking them to provide a mobile phone for Rowan. He's enlisted the help of another student from the cooking class to buddy up with Rowan, and he's joined the cooking class. Andrew and Rowan have written up an exercise plan, and then all of this is written into an action plan that's sent out to the DCPFS caseworker, the school nurse and the counsellor. So that is the step, providing the services and support. Then monitoring the support. This is the next step. Andrew and Jackson monitor Rowan's progress, and Andrew records attendance at counselling meetings, soccer club, cooking club, etc. Rowan records his own exercise routine, and the nurse monitors Rowan's medication. Andrew also records family contact events. So that's the process of the Mitford staff monitoring the services that are provided to Rowan. The next step is to review the effectiveness. How effective is this support that's being provided to meet the needs of Rowan? After 3 weeks, Rowan's plan is reviewed in a meeting that includes Jackson, Andrew, the DCPFS caseworker, the school nurse and the counsellor. Rowan also attends the first part of this meeting. The meeting concludes that the counselling is working well for Rowan, but the exercise plan is not working and should be dropped. And that's partly because Rowan just doesn't like doing it. Rowan really enjoys the cooking class and has made some friends. The soccer is going well and Rowan has some natural skill and he's played in 2 games. The regular calls to the family are going well, but he hasn't been able to contact his mother. Jackson asks Rowan's DCPFS caseworker if they can locate Rowan's mother. So Jackson's asked them to try and locate the mother. So that is the step, review effectiveness. The last part is this step here about revising. So they revise the plan by dropping the exercise routine. Then they put a plan in place to locate Rowan's mother, and Rowan is happy with this new plan. Rowan continues to make progress with his relationships with other students. He no longer has cramps and stomach aches. He enjoys the Friday cooking class and has shared cakes with other students. He played in his first inter-school soccer game and scored a goal. So that's the Rowan scenario, and that will help you with this assessment question 33 and the list of the 8 steps to meeting the needs of Rowan.